Good morning and welcome. Thank you for attending our webinar, The Groove in People with Down Syndrome. This is a recording of a webinar that Dr. Chicoine and Dr. Frank gave on August 25th. Unfortunately, we had some technical issues and we were unable to record it, so they have graciously agreed to re-record it today. There will not be a Q&A as a result, but thank you, Dr. Chicoine and Dr. Frank, for re-recording this presentation. Next slide, please. This webinar is presented by the Adult Down Syndrome Center. We are located in Park Ridge, Illinois, and we are a primary care clinic for adolescents and adults with Down syndrome. We start seeing patients at age 12. And in addition to providing clinical care, we also offer a range of supports for families as well as activities for individuals with Down syndrome. Our presenters are Dr. Brian Chicoine, who is the medical director of our center, and Dr. Katie Frank, who is the occupational therapist at our center. Next slide, please. As a reminder, this information is provided for educational purposes only, and it's not intended to serve as a medical consultation. We encourage everyone to bring this information to their primary care provider for more individualized information and support. I'm going to turn it over to Dr. Chicoine and Dr. Frank. Thank you.
Thank you, Laura. So we're going to talk about a topic that I personally find very interesting, partly because I have some of the groove, and I'm fascinated by how the groove plays out in the lives of people with Down syndrome. So we're going to look to define the groove, outline some of the advantages and disadvantages of the groove, describe problematic grooves, including the diagnosis and treatment of obsessive-compulsive disorder, and then share some strategies to address problematic grooves and establish new grooves. So let's start with what is the groove. So, we all have grooves. They help us to do automatic tasks in our daily life. For many, a part of the groove is the need to complete the entire routine from finish without interruption. So we go from start to finish on a task. So really, it's a set pattern or routine in one's actions or thoughts. And it also includes a preference for sameness, repetition, or routine. And again, including in many situations, or for many people, this desire to complete an entire task from start to finish. We call it the groove because people's behavior tends to be fairly well-worn paths or grooves, and thus the name. So there are a number of advantages of the grooves. It can give order and structure in daily life. It can increase independence. It can enhance performance and function, and it can help people manage stress. So there's a number of advantages of the groove. So for an example, so a person who wraps silverware at a restaurant, he liked the repetition, didn't get bored, did really a fine job with this task that several others in the restaurant really did not want to do, and he was excellent at that job. So oftentimes in the employment arena, it's important to find jobs that benefit from this skill or this characteristic, because many people with Down syndrome can do those types of jobs very, very well. I like to say that because of the groove, many people with Down syndrome we encounter can do tasks really at a higher level of function than might be expected solely on their level of cognition. In other words, the groove allows them to really do some things that we might not expect that they could do based on their cognitive level or IQ, if you will. So what are some examples of grooves? So, using a precise and unchanging routine to complete tasks, meticulous care of your room and personal items, everything has its place is a commonly heard phrase. Some individuals will close doors and blinds and turn lights off, very systematically and repetitiously. It might be repeating familiar phrases. Might be listening to the same music, watching the same TV show or movie, perhaps over and over and over. We often hear that we have some of our individuals with Down syndrome we serve that like to watch the same movie over and over and over, might watch it multiple times in a day and watch it day after day. without watching any other TV shows or movies. So we can all probably think of examples where these things would be a positive, where someone is able to make sure the lights are turned off before you leave the house, or having a neat room, etc. All those things can be real positive. But you can probably also think of examples where this could become excessive and problematic, and perhaps that's been an issue in your life, or perhaps that's part of the reason you're watching this webinar. We do some of these issues are habits that we really do not make a difference. Some of them are just things that people do, and we all have things that we probably do that really have no true purpose, or just things that we tend to do. So they do not all have a function, and certainly again, these can be very functional, and they're not all. We do not see all of these certainly as problems, and certainly do not see all of this as obsessive compulsive disorder, even though we might think of this repetition and this need for sameness as being something that you might see with obsessive compulsive disorder. And we will talk about that in a little bit here. But certainly we would feel strongly that not all of this fits into that category, and in many places or many times it's very functional and actually a real advantage. And again, some of it may just be personal preference or societal norms or cultural norms, again, that may be different from person to person. So what are some of the possible disadvantages? So I like to say that most of the time the groove is good until it's not. And it seems probably a little silly, but the groove can have many advantages, as I just mentioned, but sometimes it can go awry. So certainly if there's a disadvantage, if it becomes very inflexible, if the person is so intent on doing whatever the task is or behavior, whatever it is, and is not able to participate in other activities, or is not able to do anything else, or not get other things done that need to get done. Sometimes it can relate to difficulty with transitions. So the person, we talked about wanting to complete a task all the way through, and sometimes if a task is not finished and it's time to move on to the next thing, that can be very challenging for some individuals. Sometimes it'd be difficulty with unpredictable changes. So the person is so used to doing something one way, and then, as happens in life, something happens, and that not able to do that thing, and that can become very upsetting. And sometimes it can be difficult to generalize skills and knowledge. So this is often tied in with cognitive abilities and the ability to think in abstract or only concrete thinking. Many individuals with Down syndrome think primarily in concrete thinking. And so they're not able to take something they've learned in one situation and apply it to another. And some of that is the groove as well. They're tied into doing it in that one situation, and they have a hard time changing that groove to a different situation, or making small changes in the behavior that would be necessary in a different environment. So some people are not able to generalize these grooves across multiple settings or situations, and that sometimes can be an issue as well. So when there's a change, that could be an important issue to consider. And so that's just something that comes up. And sometimes then it becomes a coping mechanism that goes awry. So the groove can become less functional. It can become more or less rigid. And also there may be a variety of causes for that. It may be a relationship to stress, to pain or physical ailment, to mental illness, to dementia. We see some individuals with dementia that have either an increase or a decrease in the groove, or sometimes it's an increase beginning and then a decrease later, or vice versa. So the number of reasons, like can maybe communication issue, can be a sensory issue. The person's having something that is bothering them from a sensory standpoint that it causes the groove to change, or it can be an environmental issue. We've seen a number of people struggle somewhat with this during COVID, where it's prevented people from doing many of their grooves, and that has been challenging for some individuals. As we'll talk about new grooves and changing grooves and replacing grooves, Dr. Frank will talk a great deal about that shortly. That has been very instrumental in helping a lot of people with Down syndrome manage the pandemic very well. So these grooves represent a pre-existing tendency or pathway which then become a natural conduit for expressing stress. So we see a lot of, whatever the underlying contributing cause to the changes, often the result, the change in the groove is sort of the common denominator, the common factor, where whatever the cause was, it ends up causing this change in the groove, and we see that as a common thing. So the change in the groove is something we see very commonly, and has lots of reasons why that can occur, as the list which would suggest. So how do we manage the groove? First off, the question is, when should the groove be challenged? Should we just let the groove be? But certainly when it impacts safety, particularly if the person is, doing an activity that's in an environment where it's not safe, that would certainly be an issue, or doing something that in and of itself is not safe. Insisting on turning the stove on or leaving the stove, things like that, those would clearly be things that would not be things we'd want to see continue. When it impacts function, when the person gets so stuck on doing something that they can't do anything else, they're needing to brush their teeth for hours or get dressed for a very long period of time, and then they can't get out of the house and participate in school or work or other activities. When it impacts the family, sometimes it's it's just the person is pretty stuck on doing this, and it's preventing the family from participating in activities because the person need to do something repetitively. And the other place we encourage to consider the groove to be challenged, and Dr. Frank will talk more about this in a little bit, would be periodically to promote flexibility. So just trying to build a little flexibility into the groove, respecting that the person has this groove, and not necessarily trying to change it, but at least occasionally introduce a little flexibility to so that the person has this sense that flexibility is also an important piece of function. And then in certain environments, there may be places, for example, someone's sitting in their usual spot on the bus, and they get on the bus and someone else is in their seat. That may be fine at home with the kitchen table where everyone has a seat at the kitchen table, but doing it on a bus and telling someone to get out of their seat probably is not going to be that functional. So that certainly would be a place to consider challenging the groove as well. We certainly don't recommend challenging it all the time. We don't look at parents are not therapists 100% of the time. This is something that we want to work on building into life and addressing. When would be the optimal times to help address the need for change, or allowing the groove to continue. And Dr. Frank will talk more about that shortly. So we really look at this as a continuum. So really from the most functional. So again, people they have a job that, they need repetition, they need sameness, it needs to be done the same way each time. That can be a very functional skill to have the groove. And then it can become less functional and really not functional, where the person has to, have every item in the room just so, and they're missing school or missing work because they can't stop doing that task. And then certainly when it becomes to a point where it would fit into the criteria for obsessive-compulsive disorder. And then really it becomes an impediment to life. People can't move on to the next task. They will lose their jobs. Years ago, we saw a gentleman that lived in a residential facility, and he was very obsessed with cleaning. And for a long time, it was okay. He was very good at cleaning. His room was excellent. Was very clean. He was able to participate in a lot of other activities. It was a very functional thing for him. At one point, the overnight staff that lived in his residential facility, it was their job to do some additional cleaning things overnight. And he became so concerned that they were not doing the job well enough that he stayed up all night and sort of supervised them. And then that was a problem the next day because he was tired. And so he became less functional, not only from the standpoint of being so fixated on the cleaning, but also that he wasn't able to participate in activities or go to work the next day because he was so tired from being up all night. We've had individuals that were very meticulous about cleaning, for example, restrooms, and the customers couldn't use the restroom because the person would be in there for such a lengthy time, just very spotless, but again, not so functional when there's a long line waiting to get into the restroom at the restaurant. But people that were instructed to bus, for example, tables 1, 2, 3, and 4, and felt very compelled to do it in that order, 1, 2, 3, and 4. That worked well if table 1 finished and then table 2 and table 3 and table 4. But unfortunately, if table 3 finished before table 2, this individual would then quickly clear table 2, even though they weren't finished eating, and then to be able to get on to table 3, which obviously is not functional, and actually ended up he had to do a different job in that restaurant because he was so fixated on that. And then the other issue is as you look at this continuum is how bothersome is the groove is to families, and how much does it impact the life of the individual and the family, and then where does that fit in the continuum of functionality or not being functional. So I'm going to stop, and I'm going to turn it over to Dr. Frank to discuss some strategies.
Thank you, Dr. Chicoine. So as an occupational therapist, I don't always think about it as the groove. I really think about it as helping people function well using the strategies we're going to talk about, but also maybe then challenging it also using these strategies. Next slide. So the first strategy is really to educate others. And sometimes you do not need to challenge the groove. It isn't about changing the person, but actually changing the environment. And therefore, you need to educate others. And Dr. Chicoine has mentioned this, when he talked about our friend who worked in a restaurant. So I had a friend who worked in a cafeteria at a local college, and he was also responsible for wiping down the tables during lunchtime. And while he didn't necessarily have it set in his mind that he had to do table 1, 2, 3, and 4, that was just easiest for him. However, it was very challenging during the lunch hour because people were coming and sitting and then getting up, and he didn't have time or the ability to wipe down the table between each visitor. And so he became very frustrated and started not liking his job. And so his family ended up speaking with his supervisor, and they decided perhaps he would be best wiping down the tables before lunch and after lunch. And then actually during the lunch hour, he was assigned a different job of washing the dishes. And then his job became more enjoyable and he became successful. So again, it wasn't about changing him, but the environment. And we did this through educating his staff. We also know that many times individuals with Down syndrome like to complete a task without interruption. And so we have another individual who works at a company, and one of his jobs is to empty the dishwasher. And one of his coworkers, who I know very well, likes to empty his own dishwasher, and he doesn't want to bother his coworker with Down syndrome to help him do his job. So when the individual with Down syndrome comes over to his workstation, usually my friend is like, nope, my dishwasher is not dirty. You don't have to empty it. And that impacts the person with Down syndrome's ability to do his job because he knows he's supposed to empty that dishwasher before he moves on to the next station to empty that dishwasher. So I just told my friend, hey, when he comes over, please just let him empty the dishwasher as long as it's clean. And then that way he can move on with his job, and it's going to make it easier for everybody. When we do educate those who, everyone who helps that person with Down syndrome, it could be other family members, it could be the boss or fellow employees, teachers, support staff, but sometimes it may even be reminding yourself that this is something that person with Down syndrome needs to do in order to get through the task. And if it isn't impacting their safety or function, perhaps you can just adjust your behaviors around the groove to allow it to take place. Next slide. Another strategy is to encourage flexibility. And in the mental wellness book, it's referred to as the F word because individuals with Down syndrome don't often like the word flexibility. They see it as a negative word. So the first way to do that is to pick a behavior that is possible to change. And a question to ask yourself, is the behavior just a nuisance to the family, or is it truly a behavior that impacts their safety? And if it's a nuisance, perhaps we try to adjust ourselves or the environment. But if it's really impacting their safety, then it's something that we should address. And then it's important to pick a time to encourage flexibility. So as Dr. Chicoine mentioned, it's not something that we need to do 100% of the time. So I like to pick a day or a time during the day when there isn't such an urgency to complete a task, and that would be a good time to work on encouraging flexibility. So even this doesn't have to do with the groove, but even when I work on dressing tasks, Oftentimes individuals, when they're learning to dress and undress, undressing's easier. So we have them start with that, and maybe they get themselves undressed at night and then into their pajamas because maybe part of the bedtime routine, there's not such an urgent time. They have more flexibility. They can start the routine a little earlier. Whereas in the morning, it would be hard to have them get out of their pajamas and into their clothes for school or work because there's less time in the morning because they need to get out of the house. Or maybe you work on it during the weekends because there's just not so much pressure. You also want to provide alternative behaviors that are more appropriate. And this is where you offer choice. So maybe if the morning routine takes too long, suggest selecting the clothes the night before as part of the evening routine. Or maybe if takes too long to pack their lunch, they can pack their lunch the night before and leave it in the fridge so that they know in the morning that they just have to get dressed, get their lunch out of the fridge, put it in their bag, and they can be out the door. It's also important to teach a new behavior, when teaching a new behavior, to break that task down into manageable steps. And as OTs, we call this activity analysis. And everything seems just a little bit more manageable when we break tasks down into smaller steps. And it's a great way to teach the behavior. It's a great way to practice the behavior. And you can also see where the challenge is in learning that new step. And then you might even have to break the task down into even smaller steps. And one way to help us do this is to use visual supports. And you're going to hear me talk about visual supports throughout this presentation. And it's because visual supports can be used to help manage expectations or set limits or increase or maintain independence. And so in this case, they can be used to offer choices to help establish flexibility. So do you want to do this task first or this task first? Or today is a shower day. Do you want to shower in the morning or in the evening? All of these ways are different opportunities to offer choice. It's also important to make sure all participants are open to change and not stressed during the teaching. And this is both for the caregiver as well as the person with Down syndrome. And then the last strategy to help encourage flexibility is just to use the word flexible and incorporate it into your language throughout the day and point out when others are being flexible. And this is a great way for the person with Down syndrome to know that it's not just them that has to be flexible, that other people around them. And so it's not just because they have Down syndrome they need to be flexible, but all people need to work on being flexible more often. Next slide. So another strategy is to help set expectations. And I had already mentioned before that visual supports are a great way to help us do this. And so the first thing that we can do when we set expectations is give choices. And this also helps to encourage flexibility. So you can see in the visual to the right with the 3 green boxes, that is a choice board. So we can say, do you want to do this, this, or this? Or these are the 3 things you're to do today. And this is a great way to help challenge a groove because you might have 2 of their activities that they prefer and that third activity that's not quite part of the groove that you can add in there, and that's going to help challenge the groove and build in flexibility, but also set expectations. You might also, when you give choices, want to limit the number of options for when something can be done. And so we'll talk about this a lot, like with making the bed. We know that can take a long time in the morning, so perhaps we give them the choice that they do it when they come home in the afternoon so that it doesn't take so long in the morning and they can get out the door. We also want to help set guidelines for the individual. And this could be, maybe they like to color and that's their groove, and that's great. But we might set a timeline for it, like you can color for an hour and then you come spend time with the family. Or you get to do this activity and then that. And so we can use a first then board, which we're going to talk about in a minute. And again, using visuals. So there are other examples of visuals here. We have the one on the bottom that just is going to help maintain independence. Maybe they take a really long time in the shower. So we have this step-by-step visual to show them every step they need to take. So maybe they don't get hung up on one step and then spend a long time in the shower. Or perhaps it's a morning routine. So here on the far right, you have the morning routine where they wake up and they use the restroom and eat breakfast. And again, if they know what to expect, what comes next, then they might get through the routine a little bit faster. And then setting time limits. So at the top is a timed timer, which is really great because the red disappears as the time starts to run out. But perhaps someone doesn't like that, or they don't like the sound of a timer. Maybe you can set an alarm on their phone. You can always use the oven. There's a variety of timers you can use. And again, with that shower routine, perhaps someone takes a long shower just because they like to, and you don't want the high water bill, right? Or you want someone else to be able to have hot water after them. We've heard of individuals who have shower playlists, so they know that when the songs are over, it's time for them to get out. Perhaps they have even voices kind of chimed in to the song, into the music, that remind them when they need to move on to the next step. So music is a great way to help set time limits. All right, next slide. It's also important to practice social skills. And, Dr. Chicoine mentioned that when someone likes to sit in the same seat, perhaps it's not a challenge when they're at home and they have their seat at the kitchen table, but if they were to happen to get onto the bus and someone was sitting in their seat, what would they do? Well, if we were giving them the skills of compromise or flexible thinking, asking for help, managing emotions, all of these skills to help them so that perhaps they can help manage themselves in their groove and not act inappropriately. And it's a great time to role play different scenarios. So you get on the bus and someone's in your seat. What can you do? And you help them practice this at home. And again, we talked about how generalizing skills can be challenging, but maybe we set it up so it looks like the bus at home, or the bus, but at home, or things like that, so that they can generalize those skills a little bit better. So when it comes to compromise, this is a really hard skill, and we do have a resource where we talk about there's 3 different ways to compromise. Perhaps one person gets one of the things they want and the other person gets another thing they want, but not everyone gets everything they want. Or the next time, maybe one time you get both things you want, and the next time you hang out, the other person gets both things they want. Because again, compromise means we don't always get our way. And then the third way to compromise is no one gets what they want, and we decide on doing some other activity that has nothing to do with what either one of us wanted before. And then we know that being told no is hard. We don't like to hear it. Individuals with Down syndrome don't like to hear it, and often aren't even told no very often. So we need to help them understand what it means. And that maybe when we're told no, this is a great opportunity to suggest a compromise. And understanding that if someone tells us no, it doesn't necessarily mean we're in trouble. And that we just have to then use flexible thinking, which is that third social skill. So flexible thinking goes along with compromise. We shouldn't always be hard like a rock. And sometimes we need to be flexible like a yoga pose. And this is something that we really need to teach to help manage those problematic grooves. It's important to ask for help. And sometimes individuals with Down syndrome fear that if they ask for help, it means that they're not as independent as everyone thinks they are. And so we need to encourage them to ask for help if they need it. And that does not mean that they're not independent, and teach them that everyone asks for help sometimes. And then perhaps you can do that during the day where you ask them for help because you're having trouble with something, so that they know that it's an okay thing to do. And sometimes when individuals can't complete their groove and we haven't educated the other people around them yet, they may act out, throwing a tantrum or yelling, right? Throwing things, and that's not okay. And so we need to help teach them skills to manage their emotions and just some other strategies so that they don't act out. We always say in our social skills group about managing emotions that it's okay to have those negative feelings of anger or frustration, things like that, but it's not okay to have bad behaviors with those emotions. And so here's a handout, just a simple one that we can do without any kind of equipment, that if they need to calm their breathing, they can smell a flower and blow out a candle. If they need to calm their thoughts, they can kind of squeeze their hands or count to 10. And if they need to calm their body, they can get stiff like a statue and loose like one of those inflatable men. And those are things that could be easy, that they could step away, they could ask for help, whatever it might be, but they need to learn to manage their emotions, because that would not be appropriate in a work setting. And then the final thing is, again, kind of going along with the managing emotions, is socially appropriate behavior and manners, and that it's important to have good manners. So again, when that person's sitting in our seat on the bus, it would be inappropriate to tell them to just move. It would also be inappropriate just to sit on their lap, right? So we need to teach them that it would be more appropriate for them to just pick another seat, and hopefully then the next day they would get their seat back. And again, that's teaching them that that's also a compromise, even if they're not asking that person to compromise with them. Next slide. So one of the final strategies is implementation. And so the one way we can help implement some of these changes is to prepare the body. And so that would be through providing some sensory input. So each day our body kind of acts like a teeter-totter, and it has its highs and lows. But when our body has its highs and lows, we are not prepared for change. We want our teeter-totter to be even. And one way to help our teeter-totter be even is to provide sensory input throughout the day. And so the top handout right there is just one of the sensory handouts we have about joint compression. And it's kind of like providing a mini massage. It helps kind of reset the body so that we are more open to change and transitions. So this is something that would be really great if we want to start challenging a groove. We want to make sure that their body is ready for that. Perhaps you pair the problematic groove with another desired activity. And this is where we can use a first then. So first we make the bed, and then we eat breakfast, hoping that the motivation to eat may speed up the lengthy process of making the bed. Or first we color for an hour, and then we can spend time with family. We also know that pairing changes together can also help challenge the groove. So oftentimes here in the clinic, we recommend when someone needs to get orthotics that they also get a new pair of shoes, because the new orthotics in their current shoes, they're not going to tolerate very well because it's a change. But if both changes together, the orthotics and new shoes, it makes it more tolerable. We can also use motivating dates. So maybe a holiday that's their favorite, Christmas or New Year's, or maybe even their birthday. And this can help change the behavior. So by your birthday, we can do XYZ, whatever that new behavior is. Or just this week, I heard that someone wanted their son to sleep in his bedroom because for months and months he'd been sleeping in the living room on the couch, and that's really impacting the family. But he refused to sleep in his bedroom. Well, over the summer he went to camp, and when he came back from camp, they just said, all right, you're going up to your bedroom to sleep tonight. And sure enough, it hasn't been super easy, but every night he has slept in his bedroom, although he has come and asked for, his mom maybe to sleep nearby. But the past 2 nights, he actually slept in his bedroom through the night without asking for help. And so this is a huge change. And the family was able to pair him coming back from camp and saying, you were just gone for 7 weeks at camp and you did awesome. So let's try having you sleep in your bedroom tonight. And it worked. Again, it doesn't work all the time, but those are great opportunities to help challenge the group. So now we're going to go over some common groove scenarios and how to incorporate those previously mentioned strategies to help challenge some of them. Next slide. So the first one is lengthy routines. So we know that many individuals have a longer morning routine or bedtime routine. And so oftentimes this is where you can give choices, you can set guidelines, use time limits, or even use visual supports. So we talk about making the bed a lot, but they usually prefer to have their pillows or their stuffed animals or whatever it might be in the exact same place every day. And they might have to move it a few times to know that it's exactly at the right spot. So perhaps you limit the number of pillows or stuffed animals, or again, move making the bed to later in the day when they have more time. We know that taking long showers at bedtime could be a problem. So setting those time limits. And again, using a playlist could help with that, especially if they don't like the sound or they'll just ignore a timer going off. Just in general, getting ready can be hard. So this is where we could use a visual support for the routine. Or again, using a timer to know when move to the next step of the routine. Or we lay out the clothing the night before. Or we offer choices. Do you want this outfit or this outfit? Perhaps only having a few outfits hanging in their closet could also assist with that, so it's not so overwhelming. And then we also know that overall slowness can be an issue. And this is a great time to incorporate sensory input. So maybe doing that joint compression or giving a big bear hug or doing some kind of quick activity to help kind of jump start their body into being a little bit more active and open to change. And then you can also use that visual support, some schedule so that they know what step is expected next, and perhaps that will help them move through the routine a little quicker. We also hear that something that can impact a morning routine might be that they have to pack all of these things into their backpack. You know, they like a certain bag of pencils, and then they need their markers, and then they need some magazines, and then they need some notebooks. And so you can have a list or a visual with the pictures, or just identify you can only bring one bag of pencils and one magazine and one notebook with you. And this can help them pack their bag in a shorter amount of time and get out the door. Next slide, please. So we've talked about this, that individuals with Down syndrome have difficulty generalizing skills across different environments. And so what they learn in one setting, they may have a challenge implementing in another setting. But this can be beneficial with the groove, as we can have different routines in different environments that may be more appropriate. So for instance, someone's chore at home is to clean their bathroom. And so they can clean their bathroom whenever they want, and it doesn't interfere with anyone else using it. However, at work, they may need to clean the bathroom as part of their routine at a set time. And this could be a great opportunity for a work groove versus a home groove, and less of a worry that they're going to get frustrated at work because they cannot complete their job. So they don't carry over the groove from home into work. They just know that at work, they have a set time to clean the bathroom, and at home, they can clean it whenever they want. Oftentimes, there's different routines on vacation, or for individuals that travel between a group home and their family home, or maybe mom's house versus dad's house or their grandparents' house. And so you want to try to incorporate the desired routine, but this is a great time to also work on flexibility. And you can set up different guidelines. You can use visual supports to help establish the new groove. And really, in general, pairing changes together can establish more functional grooves and eliminate problematic grooves. And a move to a new home is really a great time to establish this new routine. Or again, with those dates or changes in the environment, going from camp, coming back home. It's a great time to just set a new guideline, establish a new routine. We've seen this a lot during COVID. So different routines were established during COVID, but now people are going back to school in person, people are returning to work. So it's a great time to challenge that old routine and get a new routine. We have to get out the door. So we're only going to do 3 steps in the morning. We're going to move the shower to the night because that takes too long. So we're just going to get dressed, eat breakfast, and pack our bag and leave, things like that. So this is a great time to challenge the groove and work on generalizing skills. Next slide. We know that individuals have difficulty completing job tasks kind of in 2 different ways, and we've talked about this, whether it's that they need to complete the task in a certain order, or they have a hard time when they're interrupted. So maybe they're interrupted, and so then they have to start back at the very beginning of their routine. So here are some strategies to help with that. And we can think about, Sue being great at her job because she knows her routine is to wipe the menus and then roll the silverware and then clean the restroom. However, when she goes to clean the restroom, someone is in there. And she does know she shouldn't clean the restroom when someone's in there. But instead, she just knocks on the door continuously and tells them to come out so she can clean the bathroom. Well, this would be an opportunity to educate the supervisor on the groove, right? And perhaps rearrange the order of the jobs so that the bathroom is cleaned when the restaurant opens and she doesn't have to worry about cleaning the bathroom later. Maybe you role play scenarios with Sue that what to do when the bathroom door is locked. You can also set rules at work when the bathroom door is locked and maybe ask the supervisor for help. So again, teaching them those social skills to ask for help. And as far as being interrupted at work, Chris's responsibility is to bring in the carts from the parking lot. And Chris is very methodical about selecting the carts to bring in, but there was a problem one day and there weren't any carts inside for the shoppers. So the supervisor came out and he started to help Chris take the carts in, but that interrupted Chris's groove. So he got very frustrated and yelled at his supervisor. So we could use this opportunity to talk with Chris's boss about the groove and why he may have acted the way he did. Or we can use visuals to help Chris know when to bring in the carts. Perhaps he'll check each parking lane and bring in one parking lane at a time, or maybe every 5 carts he gets, he'll bring them in and then return to the parking lot. And again, this would be a great opportunity to help practice managing emotions, giving him strategies to do if he gets upset with his boss, because we wouldn't want Chris to lose his job. Next slide. So we've mentioned this a bunch about sitting in the same spot. So what happens if someone always sits in the same seat on the train or the bus on their way to work, and when they get on, they notice someone sitting in their seat? Perhaps they just go sit on their lap, or they tell them to move, or they just get off the train or bus and wait for the next one because they want their seat, and then they're late for work. Right? If it isn't the same seat on the bus, maybe it's seat at work or school or other activities. So in that case, it would be important to educate the staff or other participants, perhaps even just assign seats, because that's easier. Maybe to build in flexibility, you can work on taking turns. The person gets their seat a couple days of the week, and then they have to sit somewhere else the other days of the week. Maybe we even create a visual support to help remind them of this new schedule. You can also give them another task. So here at the clinic, when we were doing groups in person for Zumba, people tend to have their, the exact same spot they wanted to stand in Zumba. And then perhaps they miss a few weeks and a new participant comes and they just take over that spot because it's open. And then that person comes back and they want their spot. So they stand next to the person, and then neither person can complete Zumba because they're too close. So maybe you give them another task. If you stand over here by the music, you can turn the music on and off to help the instructor. Or maybe you can incorporate dance moves that people get out of their spots and stand in a circle, or you can have lines or boxes or circles about where people can stand. And this is a great opportunity to practice taking turns and compromise, and even asking for help when they see maybe someone else is in their seat or standing or sitting where they want to be. Next slide. Many individuals also like to wear the same outfit. And if you don't want to change their groove, it's fine to do laundry every night or have multiple sets of that same outfit so that they can wear the same outfit every day, but you always know it's clean. But this is also a great opportunity to build in flexibility. So maybe you limit options in the closet, which give choices, but also encourages flexibility. So that outfit isn't one of the options, and it's all these other options, and they just have to select one. Or you establish that they have clothes for home versus clothes they wear in the community, or clothes for the week and clothes for the weekend. You can also establish days of the week that they can wear that outfit, and then the other days where they need to select a new outfit. And this is a great time to incorporate visuals. So whether it's a social story to talk about how we need to wear clean clothes and what dirty clothes are and where they go, or whether it's the calendar so they know which day of the week they get to wear their preferred outfit, things like that. Next slide. So for many of the grooves, we know that individuals with Down syndrome tend to get stuck, and all of these strategies can help someone get unstuck. So we talked about setting guidelines and using visuals and working with the individual to set time limits and using some of those sensory strategies and pairing the problematic groove with another desired activity. But sometimes we might want to take a less functional groove and make it a little bit more functional instead of just stopping it altogether. So perhaps someone repeats the same words or phrases all of the time, right? And that can get a little annoying for the family or for other people that they are with during the day. So perhaps you have a visual that they can refer to that answers that question for them, so that when they ask, they're still getting that response, but you don't have to be the one that gives them. You can just say, what's your picture say, or what's your list say? And then, it's wonderful that someone wants to make their bed every morning. Perhaps to lessen that time, you remove those pillows or stuffed animals that impact their ability to complete the task in a short amount of time, or allow them to make their bed later in the day when it's less of an issue. So again, you're able to still let them have an aspect of their groove, but you help them make it more functional. And next slide. We do often need to help someone get unstuck first in order to help establish a new, more productive groove. So again, setting guidelines and using visuals, pairing with another change of preferred activity, and building in flexibility can help us establish that new groove. So we talked about whether it's moving into a new home or whether it's around a birthday or holiday, or like I said, even now with school starting, these are great opportunities to establish a new groove and to help build in flexibility with the schedule. So we can use visuals to help with that. And again, it's also going to teach that new groove to help them maintain their independence. So in summary, these next slide. These strategies can help be used for those problematic grooves or to help establish new grooves, or even to help with the obsessive-compulsive behaviors that Dr. Chicoine is going to be discussing in a minute. So we want to educate others about the groove. We want to encourage and build in flexibility, set expectations, practice those social skills, and help implement and execute the new groove. So with that being said, I am going to pass it back over to Dr. Chicoine.
Thank you, Dr. Frank. So I'm going to refer back to many of the things that Dr. Frank just talked about as we go through obsessive-compulsive disorder, addressing obsessive-compulsive disorder as well. So all those things that Dr. Frank has talked about will be important here as well. So first off, what is obsessive-compulsive disorder? So it certainly is. It's repetitive behaviors. It's persistent thoughts. It tends to impair function, and certainly it limits opportunities in many situations. And we've talked about some of those as we've gone through here so far today. The interesting thing is that in people with Down syndrome, the individual is often not upset by the behavior or thoughts, but the family may be. So a compulsive behavior that we do not see very frequently in people with Down syndrome is, for example, is repetitive hand washing. Now we do see it sometimes, but not. It's a more common compulsive behavior in people without Down syndrome, but we do see it occasionally. But in individuals without Down syndrome, they're often upset by this need to repeatedly wash their hands, and they don't want to do it, and it upsets them, but they're feel compelled to do it. We don't often see that people with Down syndrome are upset by these things. They like their animals to be just so on their bed, and they like the bed to be just so, and they like things to be in this particular order. So that's not typically what we see, but what we do typically see where it becomes problematic is that the individual may get upset if the behaviors or thoughts are blocked or prevented. So if they're trying to make the bed just so, or put the animals just so, and they're blocked from doing that or prevented from doing that, then they can get upset. And then, of course, the issue where it impairs function or it limits opportunities because the person is so compelled to do things that they're not able to do other things, not able to get to work, not able to get to school, not able to enjoy activities, etc. So those would be the more common ways that this becomes problematic in people with Down syndrome, would be that the person gets upset if it's blocked, or and that's often associated with getting anxious around that activity being stopped or blocked. And then if the activity is impeding function or limiting opportunities. So really, any of the causes, as far as causes, any of the previously mentioned causes for a change in the groove that we've gone through previously in this presentation can certainly contribute to the onset of obsessive-compulsive disorder. But also there does seem to be an imbalance of neurotransmitters in the brain that probably also contribute, at least in some situations. So certainly from a treatment standpoint, we usually want to start with the non-medicinal treatments, and that's really pretty much everything we've talked about in throughout this presentation up to this point. All those strategies that Dr. Frank has talked about and recommended, all those things would be things you might also want to consider using in obsessive-compulsive disorder. The challenge in obsessive-compulsive disorder is sometimes those strategies don't work, and that really the person does need some medicinal help or medications to sort of soften the compulsiveness or reduce the anxiety associated with it, so that they then can respond to the non-medicinal strategies. So in some situations, generally we recommend starting with non-medicinal strategies, but in some situations those don't work, and it really does we need to get the medication going and then reintroducing those non-medicinal strategies, those things Dr. Frank has talked about, to see if the individual can now respond to them. And as general rules of thumb with psychological or psychiatric medications for people with Down syndrome, we recommend starting low and going slow, meaning slowly increase the medications, and start at a low dose and then slowly increasing the medications. We may need more than one medication depending on the symptoms. There may be a need for compulsiveness, treating compulsiveness. There may be an anxiety component that also needs a little different or additional treatment. And sometimes if there's a lot of agitated behavior, particularly around the compulsive behavior being blocked, that sometimes needs some strategies with medications as well to help with that. So I'm going to just talk a little bit about medications. And certainly every individual is unique, but there are some general rules of thumb. One would be the selective serotonin reuptake inhibitors, and those would be medications like sertraline or paroxetine, Zoloft or Paxil, and they have indications, FDA indications for obsessive compulsive disorder. Other medications might include the serotonin-norepinephrine reuptake inhibitors, the SNRIs, and those would include medications like venlafaxine and duloxetine. And they have indications for anxiety, but not indications for obsessive compulsive disorder. But they sometimes will be used, so what's called off-label, meaning the FDA has not approved them for that, but they do seem to benefit in some situations. But they do, again, have indications for anxiety. And then, again, because anxiety and obsessive compulsive disorder are so intertwined, I always like to say that it's no accident that the chapters in many books that are addressing mental health issues, that the OCD or obsessive compulsive disorder chapter and the anxiety chapter are next to each other, because they are very intertwined. Sometimes we use benzodiazepines, medications like lorazepam or clonazepam. More familiar with diazepam or Valium as some of the choices. Again, these do not have an indication for obsessive compulsive disorder, but again, they can be used for the anxiety. And sometimes we'll end up using one of the other medications like sertraline, but because anxiety is high at the beginning, we might start sertraline and a benzodiazepine, perhaps like lorazepam or clonazepam, with the intent that once the sertraline, which often will, these other medications will take a while to build up in the system or to have their effect. Once that effect has truly kicked in, then we can look at perhaps weaning the benzodiazepine or taking the person off of that. But at the beginning, with the high anxiety, they may need some of that together. Those two medications together may help give some immediate benefit, but also the more long-standing benefit of the selective serotonin reuptake inhibitor, for example. And then again, if agitation is part of the presentation, when it does occur, this again, particularly around when the compulsion is blocked, we might look at a mood stabilizer, such as an anti-epileptic medication or seizure medication, or sometimes an antipsychotic medication. Again, these are not FDA approved for obsessive compulsive disorder, but sometimes they're used as adjunct or add-ons to these other medications to address some of the additional symptoms that we might see in obsessive compulsive disorder. So let's go back and we'll just sort of give you some takeaway points for all we've talked about here. So the first is a groove is a preference for sameness, a routine. There is a continuum from when a groove is the most functional to when it becomes obsessive compulsive disorder. When it is functional, it can help increase independence with a variety of tasks. When it's less functional, it can lead to a lack of flexibility and difficulty with transitions or unexpected changes. There are a variety of non-medicinal strategies that Dr. Frank has shared with us that can be used to help a less functional groove get unstuck or to establish a new, more functional groove. And if obsessive compulsive disorder is diagnosed, it is possible that the non-medicinal strategies will be most effective if also paired with a medication. And in the handouts that will also be shared, there are a number of resources, particularly in our resource library, and I encourage you to consider taking a look at those. And here's the address for the resource library, and as well as we regularly put up information about health issues and people with Down syndrome on our Facebook page, and also feel welcome to sign up for our email newsletter, which we share quite a bit of information on a regular basis as well. So again, thank you very much for tuning in here with our presentation, and we hope that you find this helpful, perhaps from a standpoint of understanding that the groove has a lot of advantages, but also how to work with the individual with Down syndrome when the groove has some disadvantages. Have a great day.